so this is Off the Cuff Nurses, another episode. I am Dr. Minter.
And I'm Nurse Bryan.
Correctional Officer, Viper 22.
So we're going to talk to you today about checks and how you guys look at inmates that are at risk. Now, I'm going to be more in the background because I don't do checks as much, and you all are more into that. So that's more of your expertise. Mm-hmm. Because sometimes you have patients or inmates that are either suicidal or higher risk, and you guys can talk about what constitutes somebody as higher risk and how do you tag that patient or inmate as a higher risk. How do you determine that and then go from there? Mm-hmm. So why don't you guys talk about, like, what is an at-risk inmate?
So, in my opinion, an at-risk inmate is someone that has the ability to hurt themselves. So if it's in somebody that maybe has been trying to hurt themselves, so someone banging their head, someone trying to jump off of the sink head first. We've had that before, even like pregnant females. It's wild. People trying to swallow objects like plastic spoons and things like that. And then what we do is usually the deputy will call and say, hey, I'll give you an example. Like so-and-so is banging their head. Can you come evaluate them? So I'll evaluate them. Usually I'll get their vitals. Usually do a neuro check on them, check their pupils and everything, make sure that there's no visible injuries. And then, usually most of the time they want to keep doing that. They want to keep hitting their head. So we'll put them on suicide risk, which means that they're going into a camera cell. And then detention, we'll do 15-minute checks on them as well as watch them visually on the camera the entire time. And they will be in a, depending on the facility that you're at, they have the turtle suit? What is that thing? You know what I'm talking about? What's it called?
Yeah, I think that's called an ISO wrap.
ISO wrap.
ISO wrap.
Yeah.
It's like
the
an
green
ISO
thing.
Yeah, well, it comes in different colors. I think I saw a navy blue one, mm-hmm. A gray one, there's green. Mm-hmm. But yeah, it's an isolation wrap. It's like a heavy material with like Velcro, and the individual is naked underneath, and then they just wrap it around themselves and it Velcros. It's not the most popular option at a lot of facilities because it's cozy. So I know that sounds kind of cold, but sometimes the inmates will actually prefer to be wrapped up cozy in their own single suite.
Mm-hmm. I can see that being true.
Yes.
Yeah.
So like at the facility that I'm at, we utilize more of, it's called a paper gown. It's kind of like a giant paper towel. And it has, an armholes. The inmate can put their arms out. And it's extremely fragile. And they rip all the time, but they are not so comfortable. So, honestly, it allows, I think, the facility to kind of weed through individuals that are seriously, at risk of mm-hmm. harming themselves. Like they may have serious psych issues, mental health issues, and what have you, versus manipulative inmates that are just looking to get, extra attention or be cozy in their own single cell. So yeah. I think that's helpful.
A lot of times in intake, they'll literally tell me, they'll be like, I just want to be in my own single cell. I just mentally, I'm not okay. And I'm like, But when they because they start off by saying, I want my own single cell. They don't start off by saying,
yeah, I would.
I'm fragile mentally, or I want to hurt
it's
myself. Like and I have seen them, get the mattresses, and they'll take out the string on the side and they'll get inside of it. And they're like this. And I'll come see them like, hi. And they're like, like you said, they're cozy. So.
And then we take that away too.
Yeah.
At times.
Well, you got to have to. They just ruined it.
Yeah,
mattress. Yep. So, and then we've got, different facilities have different ways of, labeling these things, but then they've got like SR2 status, which is like non-acute. It's someone that just says that they want to hurt themselves. They may have a plan or they may not have a plan, but they're just stating, I want to hurt myself. So they'll go, in a single cell on camera with the paper gown or the suit that you talked about. depending on the facility.
Yeah, so we could like kind of circle back to the suicide risk inmates. So as far as from a detention perspective, an SR1 inmate requires constant observation in person. So in a deputy or a correctional officer has to physically stand outside the individual's cell and watch them. Whereas SR2, it's a little bit of a downgrade from SR1. They can be watched exclusively by camera. And then an officer makes their rounds and does like their 15-minute checks. But both SR categories are watched constantly. It's just that one has to be in person and one can be via camera.
And I know it's difficult because we talked about earlier how the staffing shortages, and I know they make it happen regardless. If someone needs to go SR1 and they need someone to sit there and watch the inmate, they will make it happen. But it is difficult because of the staffing shortages at all of the facilities, like everywhere you go. I mean, that's why you see online, like constantly, like they're like, correctional officer, here, hiring here. So that's also difficult. It plays a role into all of that. The other night, I had a lady come in and she was like, not saying that she wanted to hurt herself, but then when I got to the question in booking, when I had to ask her, any thoughts of wanting to hurt yourself, she's like, actually, I do. And I was like, okay, well, can you tell me what you mean by that? And she's like, well, I'm screwed. And I was like, what do you mean? And she's like, well, my crackhead daughter's going to take my house and da-da-da-da-da. But, and I'm like, you don't really want to, and I'll ask him, like, you don't actually want to hurt yourself, do you? And she's like, yes, I do. And I was like, all right. So when they say it like that, you have to put them on a status. You don't have a choice because they just told me that, and we take it very serious. You can't just take it back.
Yeah. Unfortunately, that happens a lot in the intake process.
Yeah.
Individuals that have just been arrested will come in and they'll just say something out of anger or out of frustration, like, you may as well kill me. You're taking my life away. Everything's very dramatic when you're arrested, which of course is somewhat understandable. But realistically, they'll say, that's it. Just kill me now. Or my life is over and I don't care.
Or just shoot me with your gun, even though there's no gun. But
yes, shoot me. Tase me in the face.
I'm like, okay.
And I mean, as correctional officers, we will usually say, hey, you need to be careful with how you're speaking and then it's like sometimes you can't even get those words out and the individual's going, I don't give a, just, do whatever you have to do. Just kill me. I'm serious. And then the next step is we summon the nurse. The nurse comes up, makes a determination, which is almost always the suicide risk.
Yeah.
I don't know. Maybe you can expound on that, but is there ever a time when a correctional officer says this person made suicidal statements that you guys wouldn't put them on suicide risk status?
I always do. Yeah. I know everyone can, sometimes the patient or inmate may say, I never said that, but I'm sorry, but if I trust our deputies, and if they say to me that they made a statement, then I'm going to put them on SR, because we can't go back and say, I wish I would have put them on SR. I wish I could have done that differently. And then they go and, try to hang themselves or whatever they do, cut themselves. I would rather just say, let's do it now than say, I wish I did.
What if they just killed somebody and it's homicidal?
Well, we used to, that used to be grounds for suicide risk as well. I remember when I first started working where I work, and if the individual was homicidal or suicidal, they were treated exactly the same. They were placed on suicide risk status, which I guess was a way to just kind of isolate them, protect them and others. But I don't know if that's the case anymore. Do you?
It seems like we're kind of doing away with the high profile charges and putting them on statuses just due to that. I can't really expand upon the reasoning as to why, but I know that we're kind of getting away from that. We're not really doing that anymore.
If you have an individual, during the process, like from the point of intake or even once they get to housing where they're super aggressive and they want to harm other inmates or staff or anything like that, at our facility we have something called Red Dot, which means it's just another way to isolate them to a single cell. Everywhere they go, they're shackled and handcuffed. Everywhere they go, they're accompanied by 2 correctional officers. Just a way to kind of step up the safety a little bit and step up the security of that individual. So that's a direction that we can go. And then, of course, disciplinary wise, you could put them on segregation status just out of like pre-disciplinary segregation. Like, especially if the person has shown a pattern of poor behavior. Like, yesterday they were in this housing area and they got into a fight, and then you move them to another general population housing area and they threw a chair at someone. Well, obviously they're showing a pattern of not being able to get along with others. They're not playing well. So they need to go to a single cell. And sometimes the way to get that done is pre-disciplinary segregation. Or it may be something mental health related. And that's when we call the nurse and we have them do an evaluation. A nurse is always going to do an evaluation before we place an inmate in a single cell anyway. And I think the reason for that is just to kind of rule out that there's not something medical or mental health wise going on with that individual.
Right. And I have a question for you too. So with the red dot status, I mean, what has to happen in order for them to be on red dot? Like I've heard them say, if they punch a deputy, they would be on red dot. What else would they be on red dot status for?
Well, typically there's really two roads. So it's red dot aggressive or red dot escape risk.
Oh, okay.
So sometimes when an individual comes from another facility, maybe, 15 years ago, they were at some other jail or prison and they tried to escape, whether they were successful or not. That's all notated and documented, and it's part of their package coming into our facility, part of their history. So we would put them on red dot escape risk. That's not really the correctional officer's call or a correctional supervisor. It's more the classification section. They're responsible for finding housing for all of our inmates and categorizing them appropriately. But they rely a lot on what we tell them or what medical provides. So then the other category is red dot aggressive. And that's typically if that particular inmate has shown some kind of aggressive, negative behavior towards staff or even other inmates that just prevents them from being able to just mingle with others. Sometimes we'll place someone on red dot status in the midst of their incarceration. You know what I mean? We might get called to a cell where an inmate is throwing things around their cell and threatening to fight staff. And depending on how severe that is, the supervisor from a correctional standpoint can say, place that person on red dot status, particularly if that individual during the course of the incident injured a staff member, because that does happen. Staff members get struck in the face, they get bitten, they get things thrown at them. So depending on the severity of that, we might say, put them on red dot. And then, that's not a permanent thing forever.
Yeah, I was going to ask you that. I was going to follow up with that. Is there any, way that they can come off of that status?
Yeah, I was thinking the same thing.
Yes, yeah, absolutely. So once you place them on red dot, obviously we type in incident report. There's a section in the report where you indicate that, and then that makes the classification section aware that that person's been placed on red dot. And then typically there are meetings, treatment team meetings and classification meetings and things of that nature that happen on a regular basis. I couldn't tell you exactly how regular, maybe a couple times a month. There's a committee that actually meets and they go through like all the red dot inmates, and then they ask for a collaborative effort from everybody at the meeting, and they say, well, what's this person's history like recently? Or, do you think that it's time for them to come off red dot status? And then, as long as they start to show a pattern of better behavior with no incidents, a lot of times they do get that taken off. And then they can go back to general pop.
So they can pretty much earn it.
Absolutely.
To get that kind of taken off of them. Get back in the regular clothes.
What about the checks, though? Like, how does that work?
Well, the red dot checks, those individuals will just be single cell. So, like she said, if we have 30-minute checks, 15-minute checks, 10-minute checks. So
what's the difference on all of them?
So a red dot inmate would be a 30-minute check. That's like a standard well-being check. Basically, any inmates that are on administrative segregation all the way to general population, they're all subject to 30-minute well-being checks. That should just be the average standard for every inmate. I don't know in every facility, but in ours it is. So even in a giant open bay housing area, you still have to walk around And like in our facility, we have a guard one check. It's like a pipe. It attaches to the wall, and you hit these points throughout the unit, and then that documents in a computer system that these inmates are all being checked on a regular basis,
Basically,
every 30 minutes.
document that you're physically there
Yes.
at those areas.
Yes. And then 15-minute checks would be like the suicide risk inmates and, close observation inmates and things of that nature. But like, it's important to know that the suicide risk inmates are always constant observation, but you do have to still document the check every 15 minutes.
Meaning they're on a camera. And then you go to the cell.
Well, yes, some individual is watching, one correctional individual will be watching the cameras at all times, and they never get up and move unless they're properly relieved. And then there's another individual that walks around and actually does those physical checks. So the SR inmates are really well monitored, I would say, because it's literally constant. There should never be a time that they're not being monitored. Even when they're in their cell, I mean, their toilet is exposed. Everything is there. You can literally see everything in that cell visually. So there's no excuse for the individual to be able to harm themselves realistically.
So, but the check, you said it's, what is it, a magnet or no?
It's similar to that. It's like a button on the wall. There's these points that are attached to the wall, and then you use like a wand, and when it meets up with the point, there's a tone. And then that also registers in a system, a computer database that we use. And it's called Guard One in our facility.
So they can pull those
Yes.
logs.
So if anything ever happens, like an incident, well, if an inmate passes away, one of the first things that they do is they run those reports surrounding the time frame that happened, and they pull it, and then it's all there visually. There's a record to be able to show like all of the checks, who completed them, because every officer that's completing those checks has a number identifier that's associated with that pipe. You know what I mean? Or that wand. So there's a way to know and track exactly who did those checks and when, to make sure that they were all done appropriately.
I've seen some cases where when I review correctional cases is that they're all handwritten.
Yeah, I mean, I'm sure that across the country, not all facilities have the same systems, and there may be better systems or more poor systems. But prior to the Guard One, yes, everything was completely handwritten on paper, and we use like a timer that you just pull up on your computer, or some people even set their actual watch on their wrist for the timer, and then you manage the checks that way. But the current system, I think, is the most effective that I've seen so far.
And so the, whatever it is, the wand has got somebody's name programmed to it.
Yeah, well, when you start your shift for the night, it's associated with the post that you're on, and then of course there's a shift schedule that shows where you are. So it's very easily tracked. And like I said, in our facility, there's a lot of cameras as well. So, even if you had a question, you could look at the officer's workstation on the camera and identify, okay, it was that officer that was sitting there, and that's the person that was completing these checks.
So you can look at the log and then you can look at the camera.
Right.
That's important.
I know for me, we have unco-op checks. So we have inmates that come through. I think we had mentioned before.
What's unco-op?
It's basically an inmate that came through a booking that is unwilling to complete the booking process.
Uncooperative.
Yeah, totally uncooperative. Yeah.
Right.
So basically they get, streamlined through, and they...
What do you mean?
So they kind of bypass like fingerprinting, I think their pictures, like the mugshot.
You don't fingerprint them?
I don't think so.
No, so they essentially get expedited. It's like literally from A to Z, because they won't cooperate, and they're a risk to everybody as far as safety and security, and you don't want them to clog up your process. So you kind of just take them from the initial intake where they receive their docket number, and then you just haul them away to a single cell somewhere. And typically you search them, make sure that they don't have any weapons or contraband on them, and then they sit and marinate for a little while until they can play nice.
But then how do you know who they are?
Well, they come in and they're booked in initially when they first walk into the jail.
Yeah, but I mean, I'm not giving you my name. Like, then how do you figure out who they are?
Well, typically we do, like in our facility, they typically do participate with the first step, which is walking through the door and getting a photo taken. We kind of assist them with that first step.
Yes.
So,
I've seen that.
even though a person may not want to, they still, a staff member might hold them on the side and put them directly in front of the camera. The camera takes a photo, and then it will match them up on the computer and bring up their name.
But I mean, like, how do you, like, I haven't been arrested yet. But I mean, like, if I come in
Yes.
and I get the photo, and then, like, would that photo know who I am if I haven't been arrested?
No, we would have to build you in the system.
See, so you wouldn't know who I was.
Right, but we have your information from the arrest affidavit, which of course is key because typically, it does happen to where these individuals don't have any form of ID on them or anything. But we also have other options. We have like rapid ID, fingerprinting, things like that can be utilized. Honestly, when a person comes through intake, the most crucial aspect is everybody's safety. So it's not as much about that. If this person wants to be John Doe or she wants to be Jane Doe for a little while, we're not that worried about that because we're going to put you in a single cell. Eventually you're going to cooperate with us and then we'll get somewhere. Because, people want to make their phone calls. They want to be able to see the judge. They want to bond out and things like that. So the more that they cooperate with the process, the better off they are. The more likely those things are. So, I think the longest I've ever seen like a Jane Doe or a John Doe sit in custody before we identified them was maybe a 24-hour period. It's really not that typical.
Yeah, I've seen that where, like, I'm charting on somebody and I'm like, wait a minute, the name changed. Like, how did that name change? Or they've gotten some information and I'm like, wait a minute, your name is not, whatever. And they're like, yeah, well, I go by that name. And sometimes I go by this name. And I'm like, well, whatever it is that they finally narrowed down, whatever name the guy is. So you were saying about the
Oh, the chap. Oh, yeah. So, back to that. so
Circling
the nurse circling back. So then, where I work, the nurses check every 2 hours, like the well-being checks, just to make sure that they're doing okay. And usually, they're in their single cell, and I'll knock and be, hi, how you doing? And they'll usually tell me to go screw myself, and then I'll be like, all right, see you in 2 hours. And I go back and chart, what they were doing, how they were lying down, all of that stuff, and just making sure that they're doing all right. But there's the unco-op checks. And then I know that the medication nurses do the segregation checks, and I think that's once a shift that they'll go around and just make sure that, each person in each single cell is, okay. So, but I've never done that because I'm not the med nurse, but I think that's once a shift.
Segregation.
For non-medical reasons. Yeah.
Yeah, like mental health reasons or even like you said, red dot status.
ADSEG.
What's an ADSEG?
Administrative segregation really just means that individual has proven, like, they're not necessarily a risk, like, of harming anybody, but they've proven that they can't coexist with others. They've exhausted their housing options, so they get administratively segregated. Also, protective custody, which would be like, a very high-profile person, maybe a famous person that gets arrested in our facility, and they would be easily recognizable. So we go ahead and place them on protective custody, PC, and put them in a single cell.
So basically, anyone that is high-profile will go from a single cell up front, and then once they're in booking into the being waiting to see medical to get screened, they're in a single cell. And then from there, they go to another single cell. So they continue to just keep staying in protective custody.
Agreed. And that's kind of the same process for juveniles, too. We don't get that many juveniles that come through. Typically, those go to a juvenile center. But every once in a while, we do get one that gets brought in on adult charges. So they're supposed to be kept out of sight and sound from adult inmates. And they require 10-minute checks.
All the time?
Yes.
Oh, I didn't know that.
Like forever?
As long as they're a juvenile, yes. They're 10-minute checks their entire time in the facility.
I didn't know that this whole time.
I think there's a specific book, NCCHC book for juveniles that have standards just for juveniles.
Right.
So where you have the prison, the red prison book, the green jail book,
and then you got the blue.
you got the blue, I think it's blue, juvenile
Yep.
book. So there's a whole separate book for that. So that's probably why it's 10 minutes.
That's all medical related.
Well, yeah,
It's like
not
all the
custody,
standards
yeah.
of care for all the juveniles. Yeah.
Yeah, but it probably it spills over custody because you can't really separate everything. But yeah. So anyway, so that's checks and how we deal with uncooperative people and ADSEG people,
Special categories.
special categories. So I am Dr. Minter,
And I'm Nurse Bryan.
5 for 22.
and we are Off the Cuff Nurses, and we will see you next time.